Edwin Liu with the Colorado Center for Celiac Disease. I'm going to talk about the epidemiology part of celiac disease. And so we know it's common, right? And it's seen in every continent around the world with a prevalence rate of over 1%, typically, with a pooled prevalence rate worldwide of about 1.4%. And we also know that as an autoimmune disease, it's on the rise, just like other autoimmune diseases like type 1 diabetes and multiple sclerosis. The thing is, it's not just these things that are becoming more and more frequent over the decades. Other immune-mediated diseases, such as Crohn's disease and asthma, are also on the rise. And so why are these things becoming more common over time? You know, I mean, is it the hygiene hypothesis, or for celiac disease specifically, could it be the role of gluten? You know, the hygiene hypothesis is that sort of like our environment just becoming cleaner and cleaner, so that the immune system has less to do, and otherwise it just starts causing trouble. And so one thing we notice is that there's a decrease in the incidence of sort of like major infectious diseases that have been occurring at the same time that the immune-mediated diseases and autoimmunity, like celiac disease, are on the rise. So maybe the hygiene hypothesis plays a role. On the other hand, we do know that there's certainly going to be a role of gluten, but exactly how, we're not sure. So for example, the Swedish epidemic that took place for celiac disease in the 80s and 90s seemed to link factors surrounding gluten introduction to the onset of celiac disease in kids under age 2. So, you know, I'm just going to give you a brief introduction of like these two birth cohort studies called DAISY and TEDDY. DAISY stands for Diabetes Autoimmunity Study of the Young, and TEDDY stands for the Environmental Determinants of Diabetes in the Young. And these are birth cohort studies that follow children who have a genetic risk for celiac disease. And being a cohort study like DAISY or TEDDY, I always say it's like being under a microscope for the first 15 years of life. And the purpose of these studies is really to search for environmental triggers for celiac disease and type 1 diabetes. And so, you know, broadly, we take kids from the general population, okay, as newborns, and then we genotype them. We look for the main celiac risk genes, right, DQ2 and DQ8. And out of those, you know, it turns out that 40% of the population actually has genes like DQ2 or DQ8 that puts them at risk for celiac disease. And then we break them up into kids who have 2 copies of DQ2, which is really the big risk, okay, versus kids who have just 1 copy of DQ2, versus kids who have a DQ2 and a DQ8, versus kids who have 2 copies of DQ8, versus kids who have just 1 copy of DQ8. So these are all kids that have a risk for developing celiac disease and diabetes. And then we check the celiac antibodies, the TPG antibodies on them annually, all right? And, you know, this is the microscope part. They're followed really carefully with a lot of questionnaires. You know, when do they get their first infection, their fevers, are they using probiotics, antibiotics? We take blood samples, urine samples, stool samples, all sorts of things to try to look for triggers of the celiac disease. And so not everyone with these genes are going to go on to develop celiac disease, but in general, okay, if you've got a gene that puts you at risk, about 3% of them will go on to get the celiac disease. Okay, and when you do have celiac disease, it turns out that about half of the folks with celiac disease will have symptoms. Okay, which means the other half don't really have a whole lot of symptoms. Okay, so part of what we've learned through DAISY, and DAISY recruited newborns between 1993 and 2004, is that you know, we can see that some kids developed celiac disease and some kids didn't. And so we can start to estimate the incidence of celiac disease within this population. It turns out that like within the first 5 years, there's a pretty rapid development of celiac disease that occurred. And that rate of new cases seemed to slow down after age 10. And from this, it turns out that celiac disease may affect up to 3% of children by age 15. And if you were only to look at those who are biopsy proven, it's about 1.9%. So in Colorado, like I said, kids born between 1993 and 2004, the estimated cumulative incidence of celiac disease is about 2 to 3% by age 15. But then in TEDDY, TEDDY followed DAISY, and these are looking at kids born between 2004 and 2010. And this is unpublished still, but we're estimating that the cumulative incidence of celiac disease is at least 2% by age 10. So we're looking at a pretty high incidence, higher than sort of like what's always been quoted in the United States. And this is similar to reports that have found a high prevalence of celiac disease in Finland and Sweden. Um, and it turns out that the majority of cases probably start off in childhood, right? Because it happens so early, but it doesn't mean that adults can't develop celiac disease. We know that adults certainly can develop it when they previously didn't have it before. So then who should we be screening? I think there's a lot of arguments towards a couple factors here. One is that we should only be screening people who have symptoms. So if you look at individuals who have symptoms versus no symptoms, we know that half of all cases who have been diagnosed with celiac disease actually are subclinical, or they may be asymptomatic. Right? What about the argument that we should only be screening people who have a high risk for celiac disease? And that's sort of like this blue box here. And this is according to the NASPGHAN guidelines, where people who have type 1 diabetes or autoimmune thyroid disease, autoimmune liver disease, juvenile chronic arthritis, those with Down syndrome, Turner syndrome, Williams syndrome, those who have selective IgA deficiency, and especially those who have a family history, like a first-degree relative with celiac disease, we should be screening just those individuals. Well, it turns out that most cases actually don't have one of these known risk factors. So most people aren't even at risk that we know of, right? And it turns out that the unifying factor here is just simply having HLA DQ2 or DQ8. That's a common feature. If you have it, it's permissive for celiac disease. If you don't have it, then your chance of getting celiac disease is very, very low. So when we look at the risk of celiac disease by your HLA genotype at 10 years, remember, just by having a gene, the risk is overall about 3%. But you can start to stratify the risk of getting it based on how many copies of DQ2 or DQ8 you have. So if you have 2 copies of DQ2, then your risk through DAISY and TEDdy is like 15 to 18%. If you have 1 copy of DQ2, then your risk is 7 to 10% by 10 years. If you have 2 copies of DQ8, your risk is about 5%. And if you have just 1 copy of DQ8, that's sort of the lowest risk category, your risk is about 1.5% by 10 years. And so, I think we should be really changing the way we define who's at risk for celiac disease. It shouldn't just be because you have a family history or because you have type 1 diabetes and things like that. It's really if you have the genes in general. So, why do some people get celiac disease and others don't, right? Yeah, you start off with that baseline HLA that's permissive, but we really don't know why some people do and other people don't. And through TEDdy, we're looking at a lot of different kind of environmental factors that may be playing a role, okay? And whether it's the factors that lead to CDA, which is celiac disease autoimmunity, which is basically developing TTG or tissue transcutaneous antibodies, or actually developing celiac disease. And so it's very complex, right? I mean, these things are all interrelated, and some things may actually be low protective, some things may actually be a little bit more predisposing, but certainly there's not one unifying trait. There's nothing that's really hard hitting, okay? So there's no single factor involved in triggering autoimmunity, but in general, the big players we think are starting with baseline genes. You're gonna have diet and infections. Okay, so when we look at the genetics and other sort of immutable factors here, we know that HLA-DQ2 and DQ8 is really the strongest risk factor for celiac disease. And that basically makes celiac disease permissive. Okay, having a family history of celiac disease is a big player as well. Being female, it's about 2 to 1 over males as a risk factor. Turns out the country of birth or even the region where you were born plays a role in your risk for celiac disease. When we look at the role of diet, there have been a lot of studies that initially suggested that, like the timing of your introduction to gluten was going to play a role, but then 2 major studies, clinical trials, found that we couldn't really impact the development of celiac disease by changing the timing of gluten introduction. But it turns out that maybe the amount of gluten that you give a child, early on before 2 and 5 years of age could increase your risk. Okay, and then infections. We do know that infections probably play a role, but how much, right? And it turns out that like early life infections do predispose you, especially GI infections, especially multiple GI infections, and especially enterovirus. It may be playing a role in also developing autoimmunity in a child who's at risk. So, in general, I mean, we know that celiac disease is a public health problem, okay? In Finland, it's as high as 2%. In Sweden, it's as high as 3% of teenagers that'll have it. And that's similar to rates that we just showed you that we're finding in detailed Colorado studies, okay? And, we know that 40% of the population has one of these risk genes for celiac disease, but not everyone with the gene is going to get it, okay? Overall, about 3% of those with the gene will get it, but obviously it's higher if you've got certain gene combinations. Clinical detection can be difficult, right? And so over half of all cases are either subclinical or they could just be asymptomatic. Okay, and overall it's estimated that about 20% of all cases are actually diagnosed, which means most people with celiac disease don't even know it at this point. And there's certainly a lot of research that's being done right now to try to identify the environmental triggers for celiac disease.